This is Dr. Noman Siddiqui recording the demonstration on how to perform a TraumaCad evaluation for a patient with a hindfoot deformity. In this patient, TraumaCad can be very useful in planning because it can show how much correction needs to occur for it to be a more anatomical appearing foot. This clearly is a view that is different than most people are used to, and if you have the ability of obtaining this view, it is very dramatic as far as planning is concerned. This is a patient who's had a triple arthrodesis that's been performed for a residual clubfoot deformity, but the patient continued to have pain, and if someone obtains this view that is done on a Saltzman view box and is known as a Saltzman view, they can appreciate certain characteristics, and TraumaCad can be pretty helpful in determining how much correction one needs and can plan how to correct this deformity. As within the previous videos, the first thing is to obtain the image in the screen and then select next, and obviously go ahead and select the foot and ankle so you can go start planning your deformity correction. As we mentioned earlier, the most important step is to calibrate your image so all measurements are accurate. And in this image, given that it's not a traditional AP or lateral view, and it's known as a Saltzman view, we will go with the one that is the closest to it, and we'll call it an AP view. We're also working on the right side, so we have to select the right, even though we're seeing both extremities in the image. And next, we will calibrate our image to 2.54 centimeters, and that is already set for us, and we'll accept that. The next screen that will pop up is all the various angles, but again, we're not correcting anything in the forefoot, so we're just going to ignore these and use my favorite tool within the toolbar, and that's the interline angle. So if you select the interline angle, let's look at the normal side. If you click on the normal side, you would see that there are certain measurements that are important when you're looking at this image, and that normally involves taking the calcaneal bisection of the heel bone with respect to the long axis of the tibia. And if we draw the long axis of the tibia, you see this ridiculous number comes up 177 degrees, and that might confuse you, but all you have to do is switch these two lines around and you'll get a more acceptable angle that many of us are used to. And in this patient, there is minimal to no deformity of the hindfoot. In the frontal plane, there is barely 2 degrees of valgus, which is very normal. If you extend this down, there's another measurement that is very important when assessing the Saltzman view. Normally, the calcaneus has a relationship with respect to the tibia, and that can be measured. In normal patients, that measurement, if we take it, is anywhere from 0.5 centimeter to 1.5 centimeters. In this patient, the right side, which is the normal side, measures 1 centimeter, so it is completely normal. Now, if we take these lines and compare it to the side where we see all the staples, there is clearly a deformity. You can see the calcaneus is significantly translated laterally with respect to the tibia. But let's get some objective measurements, and if we put our lines down, we see that our calcaneal bisection with respect to our tibial bisection has some degree of valgus deformity, and that is about 11 degrees. It is also translated quite a bit laterally, and if we just extend this tibial line down, we can measure the distance between the two, and just for the sake of consistency, we'll keep it at 11 degrees. And if you measure the distance between those 2 points, it comes out to about 30 millimeters, almost 3 times what is considered normal in the normal population. So clearly, if you have this patient, you know that he has not only a hindfoot frontal plane valgus deformity, but also a lateral translational deformity. And that is very important when correcting this. There are various ways to use TraumaCad to correct this. One would be to make the osteotomy at the quote-unquote apex of the deformity, which would be somewhere up in here, in the distal into mid-shaft of the tibia. And if one was going to do that, let's just move these lines out of the way. What I would suggest is we stretch one of these lines down to the level of the deformity, and say that someone was willing to perform an osteotomy proximally or distally in the distal tibia. How would that work? They would select the defined fragment feature, and they would define the fragment. Well, if you're making your osteotomy here, you would can do an opening wedge, closing wedge type of osteotomy, but let's just say they are very fancy and they've decided to do a focal dome osteotomy to correct this, and we won't talk about why that would be a good choice, but because that's for another lecture. Let's say they perform it this way, and how you would do that is make a focal dome shaped osteotomy in the distal tibia and in the fibula, but that fragment or that segment is going to rotate and correct everything in one motion. And you can use TraumaCad to plan this by taking the apex or the center point of that deformity and rotating it through here. And if you grab your handle, one can see that can be corrected pretty easily. But clearly the focal dome correction does not occur only here. It's going to occur to the center point of this deformity at the level of the ankle, and we're going to just correct this deformity until our calcaneus is in a more rectus position. And now we have reduced our translation, and we've made the correction that we need to have a more normal appearing calcaneal position with respect to the tibia. But why isn't this good? Because what's going to happen is you're going to have this large bulge on the medial side of the ankle, known as the medial malleolus. Therefore, this osteotomy would be good, but it would create a secondary deformity, likely a soft tissue deformity that the patient won't be happy about. But since we're just planning our procedures, we can kind of estimate, the amount of correction we would get if we did this osteotomy. So that's one method in correcting this deformity. But say you did not want to do that. You wanted to just strictly correct it all through the hind foot. So, well, let's see how you would do that. Instead of making your osteotomy in the distal tibia, one method would be to make an osteotomy through the tuber of the calcaneus. And that would be in the same manner. Instead of selecting the fragment to include the tibia, you would select the fragment to include just the calcaneus. And in the same manner, I would just select that whole fragment and then shift that fragment until I was happy with the alignment. And here one can see that I have translated the fragment laterally, and if I rotate the fragment, I can reduce the valgus deformity. And that's a more acceptable position of the calcaneus. If we also take our ruler, we can measure that we would reduce that deformity, which was 30 millimeters, by translating it about 18 millimeters, we would have a more normal position of the calcaneus, which would be still about 8 millimeters away from the long axis of the tibia. So a very good way to demonstrate how this deformity can be corrected and different ways in how to perform the osteotomies and where to perform the osteotomies. A very powerful teaching tool.